Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Regeneron Pharmaceuticals, Inc. and Sanofi.
Hi, I'm Dr. Wilson Pace, Chief Medical and Technology Officer at the Dartmouth Institute. I'm Professor Emeritus at the University of Colorado, Department of Family Medicine in Aurora, Colorado. Welcome to this program titled Advancing Corticosteroid Stewardship Across Airway Diseases When Steroids Signal Risk. We're also joined by a distinguished panel. Please introduce yourselves.
I'm Anju Peters. I'm an allergist immunologist at Northwestern University Feinberg School of Medicine in Chicago. I'm a professor of medicine and also hold an appointment in otolaryngology head and neck surgery at Northwestern. It's my pleasure to join you today.
Thank you, Wilson and Anju. I'm Dr. Wanda Botanical. I'm the S. Jean Emmons Endowed Professor of Pediatrics at Harvard Medical School, and I direct the Clinical Research Center at Boston Children's Hospital in Boston. I am an allergist and immunologist, and I'm delighted to be here to join in this discussion.
Welcome. Before we begin, I'd like you to consider a question as we go through the discussion. Are you considering lifetime exposure when you prescribe a burst of oral corticosteroids? For decades, corticosteroids have been the mainstay of treatment for airway inflammation for patients with asthma, COPD, and chronic rhinosinusitis with nasal polyps. While steroids are efficacious in reducing inflammation and symptoms, as we all know, they're associated with significant short and long-term adverse effects. Historically, short courses of oral corticosteroids have been seen as relatively harmless. Understanding the safe threshold for steroid exposure has shifted in response to evidence showing the risk associated with oral corticosteroid use, acute and cumulative, are more severe than we used to think. In today's discussion, we will see how to recognize cumulative steroid exposure and the associated systemic risks, and when to consider earlier treatment and potential referral. Let's take a look at a whiteboard animation to illustrate how repeated, low-dose, short-course oral corticosteroid exposure accumulates into clinically meaningful lifetime exposure. Oral corticosteroids are a common tool in managing airway diseases like asthma, COPD, and chronic rhinosinusitis with nasal polyps. Historically, short courses were seen as harmless, but we now know that even brief, repeated exposures can quietly add up to a clinically meaningful lifetime burden with risk we can no longer ignore. Consider this. In a U.S. study of 1.5 million adults, roughly 1 in 5 received a prescription for a short-term steroid burst over just 3 years, often for routine issues like respiratory infections or allergies. But here's the hidden story. Within 30 days of systemic corticosteroid initiation, there was a 5-fold increased risk of sepsis, 3-fold risk of blood clots, and almost double the risk of fractures. Risks that lingered well past the initial prescription, even at doses below 20 milligrams of prednisone per day. Another study showed that short bursts of oral corticosteroids, that is less than or equal to 14 days, significantly increased the risk of gastrointestinal bleeding, sepsis, and heart failure within 5 to 30 days. And the risks didn't vanish quickly. These effects remain elevated 31 to 90 days after initiating the oral steroid burst. Given this, what level of cumulative short course steroid exposure is associated with an increased risk of adverse outcomes? One study that compared patients with asthma with and without steroid use showed that a dose response relationship for cumulative systemic corticosteroid exposure for most adverse outcomes began at cumulative exposures of 1 to less than 2.5 grams. And for type 2 diabetes, at cumulative exposures of only 1/2 to less than 1 gram, equivalent to 4 lifetime systemic corticosteroid bursts. Alarmingly, a number of risks appear for patients with chronic airway disease, even at seemingly low exposure levels. US data show that just 1 to 3 prescriptions in a year raises the risk for pneumonia, obesity, sleep apnea, anxiety, depression, and avascular necrosis. For patients with 4 or more oral corticosteroid prescriptions, the danger climbs even higher. Here's the crucial point. Each short oral corticosteroid course may seem insignificant, and in busy, fragmented care settings, these risks may go unnoticed. But over a lifetime, they can accumulate silently, crossing the threshold into harm. It's time to count every course, connect the dots between care settings, and recognize the lasting risks, even for the short courses that were once considered safe. Andrew, we just heard that 1 to 3 prescriptions a year can raise the risk for a number of issues, including avascular necrosis. Can you speak to your experiences in these areas?
I'd be happy to, Wilson. As I mentioned earlier, I focus on chronic sinusitis as well as severe asthma. And what we know in patients with severe asthma, often it's their sinuses that may lead to an exacerbation of their asthma. And then these patients will then get courses of oral steroids for their asthma exacerbation, often for a week or 2 weeks or 3 weeks at a time. Many of these patients, because they have issues that involve both their upper and lower airways, when they have exacerbation from viruses, go to immediate care centers and urgent care centers and also get systemic corticosteroids there, in addition to getting it from their primary care physician, pulmonologist, allergist, etc. These doses all add up. And as the price paper showed us, even 500 milligrams can lead to adverse effects. So you can imagine if you get a course of 40 milligrams for a week for one exacerbation, these courses add up and then can lead to side effects that we're well aware of. And one that I'm so thankful we don't see as much now as we've had biologics, so less patients on chronic oral steroid use. But one we used to see when people were more oral steroid dependent was avascular necrosis of the hips. And sadly, this doesn't, this is something that can lead to long term disability where individuals have trouble in moving, um, walking, exercising, and just worsens other adverse effects we see of steroids. Because if you can't exercise, then you tend to gain even more weight. And this rare side effect that happens with oral steroid use doesn't show up right away. It may show up weeks or even months after someone is off their oral steroids.
Thank you. Wanda, what are your thoughts about how long the impact of a single course of oral corticosteroids can last? It indicates up to 90 days. In particular, also, can you talk about the impact on pediatric patients?
Yeah, thanks very much, Wilson. I think it's important to think about that even after you stop steroids, the adverse events or effects can persist. And it really adds up to that cumulative lifetime exposure that can really impact long term outcomes. So, just because it's easy to give and it's quick and you get relief right away, you have to remember that systemic corticosteroids have lasting adverse events, even up to 90 days, but even longer than that. And it's particularly important in pediatric patients since we worry about their long-term growth. We worry about the long-term health effects. And we know that if early on they're already receiving at least 4 lifetime bursts of systemic corticosteroids, that their risk of long-lasting adverse outcomes significantly increases.
Andrew, in adults, can you just review again the short and long-term adverse effects of oral corticosteroids for us?
Absolutely. In terms of short term, one of the biggest things that I tell my patients, it can affect your mood. However, we have really good literature, both from US and outside US. There's a good paper from Taiwan and then a paper from University of Michigan that shows short-term use of steroids, whether it be less than 2 weeks, 14 days, or less than 30 days, as Walji in the Michigan paper showed, can lead to higher risks of side effects that persist for from initiation of steroids to about 30 days, but up to 90 days, you still have some risk. And this is including risks of GI bleed, sepsis, DVTs, fracture, and even heart failure. These are risks that we don't tend to think when we give our patients short courses of steroids for asthma exacerbation. But we need to be aware that although it's a small increased risk, it does add up. In terms of long-term steroid use, we worry about the cardiac and the metabolic side effects. With steroids, we know you're at higher risk for obesity, higher risk for type 2 diabetes, but also hypertension and hypercholesterolemia. As Wanda mentioned, you worry about osteoporosis and then fracture risk. All of this adds up and just builds on itself. And finally, something that we see in adults and kids, in those who have been steroid dependent, we have to worry about adrenal suppression. That over time, patients with prednisone, whether they be on 7.5 milligrams or over, it all leads to cumulative lifetime exposure. And we see a lot of these side effects. So we know that systemic steroids, even short courses, can have significant side effects in terms of the mood. People may have trouble sleeping. Some people get extremely agitated on systemic corticosteroids. I'll tell you an example of a patient of mine who's in her early 30s. For a severe asthma exacerbation, she was on a short course of prednisone, 40 milligrams daily for 5 days. Unfortunately, the systemic steroids had an effect on her mood. On her way home from clinic, she's 5 feet tall. She took the LR public transportation in the city of Chicago and punched a 6 foot tall man on the train. This is a woman who would never do anything like this. This was unfortunately a side effect of her systemic steroids. All of us have these cases where we hear of side effects of systemic steroids that we don't tend to think of as, affecting that are long-term osteoporosis and things like that.
Thank you. Wanda, what about the pediatric population? What are the differential effects in this group?
I think in children, there are other effects that we have to really think about, particularly delayed growth, delayed puberty. The children are shorter. They often have weight gain, and you can have obesity early on in life, which increases again your risk of metabolic dysfunction, poor control of their asthma or allergic diseases. And we also often see changes in behavior as well. I have had 5-year-old children who are on systemic corticosteroids, and the parents are complaining that they are up all night and not getting any sleep or running around and becoming very, very aggressive. So we definitely see psychiatric and behavioral challenges. I've also had some patients who show evidence of adrenal insufficiency. They come in and they have like that hump behind their back of their neck. They might demonstrate a lot of weight gain. They'll get that stria on their bellies that are consistent with too much use of systemic corticosteroids. And we, even in children and adolescents, start seeing bone effects. We see that they're shorter. We see them have increased risk of fracture. And even in younger adults, you start to see cataracts, which you would never see in younger patients. So I think it's very important to think about the potential adverse events that can come from frequent systemic corticosteroid use.
Thank you. An important thing for people to understand is, why are we talking about this today? Steroids have been around for 60 years. I believe it's because we never truly have the ability to understand long latency side effects. But now that we have electronic health records fairly ubiquitous, we can look at populations for 10, 15, and 20 years that's just never really been available previously. Um, and there's not just the price paper, but others are demonstrating repeatedly that fairly low doses of lifetime accumulation of steroids can lead to persistent long-term major adverse events. In response to what we know about corticosteroids, expert consensus now emphasizes corticosteroid stewardship. What does that mean? That means identifying and understanding more closely the lifetime exposure to the person you're seeing, and also thinking more carefully about that person's trajectory and minimizing unnecessary exposure through timely intervention. With the idea to transition our mindset away from oral corticosteroids being a routine solution, what do you think about interpreting, or how do you interpret oral corticosteroid use as a marker of uncontrolled disease?
I can start with that. I think that's a very important point. It used to be, as you said, we've got more electronic medical records, so we're looking at potential side effects of systemic steroids. I also think the reason we're looking at side effects, now we have treatments that we'll talk about more with the biologics that are an option to use instead of systemic steroids, or when someone's asthma is getting worse. So we're much more cognizant of the side effects. Now, your question about looking at repeated steroid use as a marker of uncontrolled disease makes sense. Because why do people get systemic steroid bursts? It's because their asthma is getting exacerbated. So that tells us an exacerbation predicts an exacerbation the following year. More frequent exacerbations, poor lung function, poor disease control. So I definitely think asking someone about systemic steroids when I see them and follow up in my clinic as a marker of asthma control is as important as asking them how often do they have symptoms, how often are they waking up at night, how often are they using their rescue inhalers. I keep track of those systemic steroid courses because they can get them at so many places, including immediate cares or other specialists.
So, Andrew, can you describe for us the impact of biologics on oral corticosteroid use?
I think the impact of biologics on systemic corticosteroid use has been revolutionary. It used to be about 10% of my clinic were systemic steroid dependent asthmatics, many with nasal polyps. Now I have maybe a couple, and these patients are not willing to go on biologics. Biologics have very good evidence that they can reduce systemic steroid use, and similarly, as they decrease systemic steroid use in asthma based on literature that has been published, these same biologics, many of them are approved for nasal polyps and have shown reduction in need for systemic steroids for CRS with nasal polyps, which is comorbid condition seen in one-third of patients with severe asthma. And often exacerbation of the upper airways then leads to lower airway exacerbation. So I really do think biologics have changed how we manage our severe asthmatics.
Yeah, I would add as well that the thing about biologics is they block inflammatory processes that, with the same treatment, can improve outcomes in multiple diseases. We mentioned a bit about many of the new biologics really target type 2 inflammatory pathways. So these biologics can really have a broad impact on multiple diseases. And we know that they are effective in reducing systemic corticosteroid use. So when would I consider biologics? I think we always want to think about them, especially when I see a patient is not well controlled. They have frequent exacerbations. They are needing multiple doses of systemic corticosteroids. We can see that their lung function is not stable. And I, as an allergist and immunologist, I tend to have a pretty low bar on when I start thinking about biologics because I know that there's so many other diseases that they treat. I know that systemically it can block the inflammatory processes. I know that there are many different ones that are available as well. And there may even be a potential, though they haven't been definitively proven, but there may be a potential for even modifying the disease.
Currently, biologics are almost always started by a specialist. It could happen whether for pulmonary, skin, ENT, or any other conditions. As a primary care physician, I think we all need to think about kind of understanding and beginning to consider these medications, at least for more common conditions, particularly within primary care as well. I believe the willingness of primary care physicians to learn and prescribe these will become more common, at least probably for asthma and perhaps COPD. And if you're not comfortable yourself, then when you get ready to send somebody to a specialist, make sure that you've done some of the basic information, such as a CBC with diff or eosinophil counts, or if it's a pulmonary disease, getting more recent PFTs so specialists could understand pulmonary function. Uh, Hopefully, we can be great partners in figuring out when biologics can be moved forward. Let's pause for a second. I want you to think about the following. Have you considered what your patient's cumulative steroid exposure may have been over the past several years across urgent care, primary care, emergency rooms, and specialty settings? Patients with asthma, COPD, and/or nasal polyps may encounter a range of collisions across settings and that use oral corticosteroids. Andrew, how do you find practical ways to begin to understand the lifetime experience of oral corticosteroids for your patients?
So this is, I think, a little bit of a difficult thing to do, mostly because patients go and travel multiple places, go to urgent cares in many places. However, this is where electronic medical records have been of benefit because often we can see when someone's been to an urgent care, even outside my city in Chicago, I would say. So I ask my patients if they've had asthma exacerbations, if they've been to urgent care. Sometimes they may not tell me. It's if I ask them, "Have you had an asthma exacerbation?" They may not necessarily say that. They may think, "Oh, I had bronchitis," or "I had sinusitis flare." So you have to ask multiple different ways and ask them if they've had oral prednisone, oral steroids, and we document that in our electronic medical records, looking ahead in their records to make sure, seeing and confirming if they've been elsewhere, asking them a few times, and keeping track of it really helps me keep track of a patient's systemic steroid exposure. Because as you mentioned, they can get it many different places.
So, I want to talk a little more about how you use steroid exposure as a trigger, and what kind of diagnostic assessments and phenotyping you may go through. Um, and also, one of the things that I know I find commonly is patients' denial of the severity of their disease. To them, one dose of steroids is normal, kind of what you expect. Right? They've always expected. Interested in how you approach all of this.
Yeah, that's a really important question, Wilson. I think as a goal, we really want to have our patients go into remission, to really not have symptoms, to really not have exacerbations anymore. And when I see that a patient is needing multiple doses, multiple bursts of systemic corticosteroids, I know that this patient is really going down the wrong path. And we see them early in childhood, and they are high risk for developing persistent severe disease that lasts lifelong. I also think it's important for us to understand their triggers, understand maybe their environmental triggers. We try to look and see if they are allergic to anything that's exposed in their environment because we know that atopy and allergic inflammation or type 2 inflammatory processes is really important for the risk of the development of persistent lasting asthma. We also know viral exacerbations are important as well. So we always want to get an assessment of that and also response to the exposure. So if they have allergic type 2 inflammatory processes and they are exposed to a lot of things that are their triggers, then the inflammation persists and develops into lasting disease. So I think recognizing this frequent exposures, persistent inflammation, and progression of the disease is very important. And that's when we start to think about, even early on, considering a biologic, especially now some of the biologics are really now FDA approved for other conditions besides asthma and chronic rhinosinusitis and nasal pops. They really have things early on in that allergic atopic pathway, for instance, food allergy and eczema or atopic dermatitis. And I think it's also important to think about their the phenotype of these patients. Do they look like they are going down that type 2 inflammatory pathway? Are their eosinophils counts elevated, greater than 150 or 300? If you can get FeNO in clinic, the fractional exhaled nitric oxide, is that greater than 20 or 30? That shows that maybe they have a type 2 inflammatory process. Is their IgE elevated? Do they have allergic triggers? And so assessing these early on can really make an impact potentially of their lifelong trajectory, which I think is super important.
Great. Andrew, what do you have to add?
I agree with Wanda. I think these, biomarkers help guide us, the eosinophil counts, pheno, but also, as Wanda said, their phenotype. Our goal is to have sustained control, but even more so, as Wanda had mentioned earlier, maybe even remission of the asthma. And data does show that if you target inflammation earlier, you have higher likelihood of achieving remission. Those who are younger, those who have better lung function. So why not try and do all of this? If we can do it, and we keep getting evidence for this, and at the same time decrease the need for systemic steroids. So I think using these drugs, figuring out the phenotype, biomarkers all guide us in terms of helping our patients do well, not only with the airway disease, but also decrease risk of the adverse effects from the drugs we used previously to treat these type 2 inflammatory conditions a lot more.
We all recognize that oral steroids can't always be avoided. They're clearly indicated for significant exacerbations, particularly for airway related diseases. Um, but when you do use them, suggest that you try to use a lowest dose possible, shortest period of time you think you can get away with. Should monitor people for side effects. I think this is a uh, tougher, obviously, if you're an urgent care or emergency room physician. So hopefully people can follow back up with their usual asthma, COPD, or other disease clinician. Um, Avoid systemic routes when possible. I think from my perspective, particularly with the asthma area, that means to optimize their regular therapy. Check for underlying conditions and be concerned about what may happen to them for somebody that already has uh, prediabetes or other conditions. We need to be careful about how we prescribe these medications. Anju, as we have talked about previously, patients feel better quickly often on steroids, and they often request them. Um, how do we counsel patients about considering other choices?
I think this is important, and this is something where multidisciplinary teams help. If I'm seeing a patient with severe asthma and nasal polyps, I will also have him see my colleague who may be specializing, one of the surgeons for removing nasal polyps, but telling patients about the side effects of steroids. And this is built over different times by many of us who treat patients with these conditions. So patients understand. We understand their asthma is flaring. We understand when they have to have a short course of systemic steroids, but also understand that if we treat their inflammation better, whether it be with inhaled steroids or whether it be with sinus surgery or whether it be with biologics, potentially they may not have as many exacerbations and then may not need the systemic steroids as often. So, really, informing our patients is key, both of adverse effects and also other treatment options to me is very important.
Yeah, I agree with what Anju said. And again, that partnership between primary care physicians and the specialists on educating the families, educating the patients that we know that they are easy to use. Oral corticosteroids are cheap, readily available. But if you're needing them often, then we need to understand why. We need to think of ways to reduce the need for systemic corticosteroids.
How can we better establish shared ownership of a patient's steroid burden across the multidisciplinary team to ensure no one is making decisions in a vacuum? Thoughts?
Well, I think, like Angie said, the multidisciplinary team is really critical, and education between um, everyone taking care of them is important. And really, there should be open communication with the specialists and all of the physicians that are caring. Whether if they have nasal polyps, you're going to have the surgeons and other folks involved as well. And really, again, communicating and education between all of the providers and really centralized around the patient.
I would agree with Wanda on this. And, multidisciplinary collaboration and seeing what our colleagues are doing with electronic health records is easier now that these biologics can treat so many conditions. My dermatologist and I work together, my ENT and I work together, and keeping the patient, like Wanda said, in the center and working with our primary care physicians is so important. And all of us being educated on potentially that these patients can get systemic steroids in so many places, and the adverse effects add up because of the cumulative steroid doses. So, open lines of communication and collaboration is essential.
Hopefully, this conversation has convinced you that long latency side effects of oral steroids are more problematic than previously recognized. While not the focus of this conversation, we also are now becoming more aware that even inhaled corticosteroids increase the risk of long latency side effects. As clinicians, we need to be cognizant of tracking lifetime exposure and be sure not to fall into the trap of clinical inertia. One steroid requiring exacerbation a year for people with asthma is not adequate care. It not only increases the risk of oral corticosteroid side effects, another exacerbation, but also accelerates loss of lung function, as has been noted. We now have alternative therapies that have demonstrated the ability to reduce lifetime steroid exposure, both systemic as well as inhaled steroids. Get out of the mindset that one exacerbation a year is okay. Make sure you have your own stop points in your brain and when to either start or refer for alternative therapies. Anja and Wanda, thank you for the great discussion. Much appreciated your time today.
Thank you.
Thank you.
And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you.